Next slide. So the admission diagnoses that the team made was severe acute malnutrition. She was started on therapeutic milk, bronchopneumonia, and was started on ampicillin and gentamicin, both for the respiratory infection and for the malnutrition. Moderate anemia, HIV exposure, was put on or maintained on cotrimoxazole prophylaxis, and was diagnosed with scabies. Unfortunately, our referral hospitals don't typically have scabies treatment available. So she was just put on hydrocortisone cream for that. Next slide. So this is an interesting point that I hope we can discuss afterwards, but early infant diagnosis in hospitals in Mozambique is challenging. There's only 2 central hospitals in the entire country right now that have a point of care EID machine. We use INPIMA. There's other hospitals throughout the country that have a co-located health center where admitted infants can have access to timely Yamban is not one of those. And so the team had to make a presumptive HIV diagnosis. They collected a DBS for conventional PCR. They also collected a CD4 and viral load to try to help with their presumptive diagnosis. The CD4 came back with an absolute count of 1855. No percent was available as they use a INPIMA machine for their CD4. But this, with her presumptive HIV diagnosis, this infant met criteria for advanced HIV disease diagnosis, and she had a strong clinical suspicion of TB. So an expert was ordered by a gastric aspirate, which came back negative, and she also had urine lamb testing done, which came back a result of 2+. Next slide. So the hospital team initiated kind of standard pediatric treatment with RHZ and ethambutol per WHO weight band dosing, and saw a really rapid improvement in her clinical status with improvement in her cough, good weight gain, and she was discharged on day 14 of her hospitalization with plans to continue TB treatment in the local health center, to return to the hospital for her DNA PCR result, and the plan to initiate her ART after 2 weeks of TB treatment, and to receive ongoing nutritional care and pediatric follow-up. So when she came for outpatient follow-up, she was continuing to do well clinically with weight gain and nutritional recovery, resolution of her respiratory symptoms and her scabies infection. But unexpectedly, her DNA PCR result came back negative. Next slide. So this case had generated a lot of interesting discussion when it was led here locally. And for this group, I thought some of the points that would be interesting for us to discuss is how do you use, or what is the utility of urine lamb testing in HIV negative patients? This patient had her lamb test ordered when she was thought to be HIV positive. Current WHO recommendations limit the recommended use to HIV positive populations. So that's an interesting point for discussion. Something that we struggle with a little bit here in Mozambique is that as we're trying to scale up services for patients with advanced HIV disease, a lot of our hospitals are equipped to Sorry, I got muted again. Are often equipped and able to provide outpatient HIV care, but they're not set up to provide outpatient TB care. So TB can be diagnosed and treated while patients are hospitalized, but when discharged, they need to maintain their treatment through their local health centers. And for patients that need follow-up with kind of specialists at a hospital level, the fact that TB treatment can't be given from those sites is something that is occasionally a challenge, particularly if patients struggle with transportation costs and time away from work, going to appointments at different health centers. And then I also think the challenges with hospital-based EID really raised they were a factor in this case. And more recommendations that are coming out from WHO and other groups are that we should be prioritizing point of care diagnosis in exposed infants, particularly those who are most sick, like those in hospitals. And so I'd be interested to hear if other countries face these challenges. I think that's my last slide.
Yeah, great, Chris. Thank you. Can you hear me?
Yeah, thanks, Steve.
Yeah, hi, Chris. Can you put back the last slide, thanks, for me? Thanks for a very clear presentation, very interesting. And I'd like to just start with a few questions and then perhaps ask others for clarification on the case. Were you able to look back at a health chart or road to health chart to see when this child, clearly this child was severely malnourished by the time presented, but when did that weight loss begin, or did the child always fail to thrive? And I'm sensing that the likely source of exposure for this child may have been the mother. Has the mother been reviewed at all for presenting with any evidence of TB postnatally, for example? Thank you.
Thanks for those questions, Steve. Unfortunately, this was not a patient I was following personally. From what I understand from the ward team, she had weight loss for about 2 months prior to her presentation at the hospital. Her brother, is interesting, is quite wasted and has the kind of classic appearance of an infant who had perinatal HIV infection and much more developmentally delayed than she was. So there's a pretty stark contrast between the two, but she was still being breastfed, and there wasn't a perception that, you know, food insecurity or early weaning was a factor in her malnutrition. The mom was
that's what I was asking. Yeah, thank you.
Yeah, and
the mom, is she well?
But I don't know. Yeah, she's clinically well, asymptomatic. I don't know if they ordered any tests for her specifically, and that's another challenge we have, is sometimes for children who are admitted, being able to do a kind of thorough workup for their mothers, really implementing that kind of like maternal child health approach for infectious illness like TB is super important, but not always easy. But as far as I know, she just had a kind of like a symptom-based screen and not any, you know, diagnostic testing or chest radiograph.
Chris, you had a positive LAM. Are you surprised with a positive LAM in a child that's so severely malnourished? I know the child's, we think, is HIV uninfected.
Yeah.
But would not severe malnutrition also be a sort of a situation where you're likely to get a positive LAM?
Yeah, Steve, you know, for the local case presentation, we looked at the literature. There's some folks who've done some kind of meta-analyses or systematic reviews about the evidence for LAM in populations other than HIV positive patients. And certainly this seems like one of the groups that we're most likely to extend testing to in the future, is these severely malnourished patients who can have immunocompromise similar to advanced HIV. We even found a study that was done here locally, some of our colleagues, where they performed LAM in children who were malnourished, and every children that met kind of clinical or laboratory TB diagnostic criteria had a positive LAM, many of whom were not HIV positive. So the result doesn't surprise me, but our national guidelines are really clear that we're only supposed to be ordering LAM in HIV positive patients. And I know there's concerns about its sensitivity in some of our other populations, but from everything I've read, you know, the positive predictive value is pretty good. And when you do get a positive result, even in a patient who's HIV negative, that it's probably pretty strong evidence of TB infection.
Yeah, thank you. We can talk a little bit more about malnutrition in a minute. I'd like to ask others if they would have any particular questions or comments for clarification. I'm trying to, I can't see actually, but speak up or put up a hand.
Steve, this is Rita here. I do not see any comments or questions in the chat from the colleagues on the call. Maureen Sekade from Uganda has a question that has just
Right,
come in.
Maureen,
And
over to you.
over to
Over
you,
to you,
Maureen.
and to help.
Yeah.
Maureen, over to you, and to help discuss the HIV issues. Thank you.
I see that Maureen typed in the chat here, asking about a history of TB exposure. No, Maureen, there wasn't any known history of contacts. And I can see another question that was posed here in the chat by Peter, asking, I think, about the presumptive diagnosis of HIV in TB patients. In Mozambique kind of national guidelines, TB suspicion does not meet HIV presumptive diagnostic criteria, but this patient had severe acute malnutrition, and that was the criteria that kind of aligned with our, how we can go ahead about making a presumptive HIV diagnosis.
But Chris, can I just get clarification again? Is it not possible that, sorry if I'm misunderstanding, that this child has TB but not HIV?
That's what we believe. Yeah.
Yes. Sorry. Yeah.
Excellent clinical response to her TB treatment. She had positive LAM. But with her original presentation in the hospital, I think that the team did what they're supposed to do. Unfortunately, all too often when I go do supervisions, there's patients who should have had a presumptive HIV diagnosis and didn't. And this is one of those cases where the team made the presumptive diagnosis and it ended up not being, in fact, HIV.
Right. Yeah, no, thanks for that. It's interesting that recently in our meeting in Lusaka, it was again highlighted from the work of the TB Speed how common TB is being detected in children with severe acute malnutrition. It's not that presentation of severe acute malnutrition has a high probability of TB, and I think that's not something that's particularly new to anyone, but I think it's important to have recent data to confirm that we should, and that's where a LAM test may, as you've suggested, may become quite useful for diagnosis.
Yeah, I don't know, Steve, you're more part of the high level discussions about, diagnostic guidelines and screening guidelines, but has there been discussion at like a WHO or union level about kind of extending the recommended use to this patient population, or are we still waiting to accumulate more evidence about that?
No, I think the standard approach really, Chris, is that we should seek bacterial confirmation with a molecular WHO-approved rapid diagnostic test, wherever that's possible, and that would include a LAM, not just an expert, if that was the appropriate test. But I think you've highlighted the fact that LAM is thought of in the context of people with HIV/AIDS, particularly low CD4s, but this is another context where I think maybe we should be thinking more about the potential of LAM. We recently had a child here in Melbourne, preterm baby, congenital TB diagnosed from the urine as well. It's not, who was not HIV infected. I think it's something we need to think a bit more about. Yeah. It's getting the evidence that's challenging sometimes, I think.
Yeah. But
certainly LAM would be included amongst the recommended molecular rapid diagnostics. Yeah.
Yeah.
Sabine's just put something in the.
I see that. Yeah, these newer generation Fuji and other tests that might be.
Yeah, so that's be reviewed next year. There we go. Thanks, Sabine. Hot off the press. Thank you.
Mm-hmm. I see a question from Jacqueline as well from Baylor, Uganda.
Yep. Go ahead.
Yeah, Jacqueline, when patients are diagnosed at the hospital, at the time of discharge, they get transferred to their health facility to continue treatment. But though they only get registered and reported to the National TB program when they in fact sign up at their home health center. So this is something we've talked a lot about in our pediatric TB technical group, but we know we have gaps in how we've set up our monitoring and evaluation, and the patients who are diagnosed in hospitals and die before discharge or don't follow up after reporting them. actually she's on the call, and this is something about. So yeah, bridging these kind of inpatient to outpatient are challenging for us with TB right now.
Yeah.
But as more and more we're moving to try to keep the sickest patients with HIV in follow-up at hospitals where there's more specialized providers. I think if we're moving in that direction, we as a country will need to take a critical look at, our ability to provide ongoing TB treatment for them so that their care is all happening in one place and not fragmented.
Okay, well, thank you. I think Rita, it might be good now if we could move on to the next presentation. But thanks very much, Chris. That was brilliant. Thank you.
Thank you very much,
Steve and Chris. And indeed, let's move on to the next presentation. I believe you, Steve, have kindly promised to introduce our next presenter, who is Dr. Isa Sabi from Tanzania. So over to you, Steve, once more. Thank you.
Yeah, no. Well, you've just done that. Dr. Isa, please go ahead and present your cases from Tanzania. I've seen a number of those, so thank you.
Yes, good afternoon, everyone. Yeah, thank you. So I'm going to take you through a summary of the cases that we have seen. I'm not sure if you did some editing on these slides, or if no, I can share the slide which I have.
We can see the slides, Dr. Isa, yeah?
Yeah, but I did some rearrangement unless if you did some modification, but if not, I can share the slide which I have. If fine.
No, that was, the modifications were very minor. This is fine, what you have, yeah. Yeah.
Okay. Yeah, so just briefly.
Sorry to interrupt, Dr. Isa. Can people who are not, can everybody else mute except Dr. Isa, please? Thank you.
Okay. Yeah, so my name is Isa Sabi. I'm a pediatrician working with the National Institute for Medical Research in Tanzania, Mbeya, but also I work closely with the national TB programs. So our setup is a research center. So we see mostly patients who we want to enroll into different studies. So for pediatric, we have a childhood TB clinic in our hospital, but also we receive referral cases from peripheral health facilities, the lower level health facilities, but those children usually are referred for us just specifically for evaluation for TB. So we do not do most of the other investigation, but this one is done as part of the hospital investigation. But also we can also recommend further investigation, in which then you have to refer back to the hospital for those evaluations. So the case which I present here were participants which we referred, the potential participants who referred for consideration to participate in one of the studies. Most of them were diagnostic studies as well. So the first one was 2.5 years old female with a body weight of 7.2 kilo, presented with a complaint of fed-up strife, the calf, for 10 days. So the mother reported the child had fed-up strife, which was preceded with difficulty, poor feeding history, calf, which was followed up with the vomiting or sputum mixed with the blood, but also the condition was associated with night sweat for about 1 week. There are no known TB contact reported. Next. Yeah, this was a patient who was known to have cerebral palsy, and was on treatment, was phenobarbital, but also folic acid. And has a history of being admitted twice in a year due to severe malnutrition. On the general examination, the child was febrile. That was on the day of assessment at the time of enrollment. Respiratory rate was 20, pass rate was 127, but the oxygen saturation of 98, with a height of 7.8, the MOAC of 12.3 centimeter, and the weight for head score -3 standard deviation. So severe acute malnutrition. On examination, he had no lymph node palpable. Back. Yes, on assessment for TB score, is the addition of the chest X, so the provision diagnosis of cerebral palsy, which was known, but also tuberculosis and severe acute malnutrition. This was the lab abnormalities, lymphocytosis, but also HB of 11.1, HIV negative, but also the tuberculin skin test also was negative. Next. Next. Yeah, maybe we were supposed to see the X-ray first before the result, but yeah, we can proceed. But this was the X-ray, which the quality was not good. The rotation was not good. Also, probably maybe it was overexposed. So we could, yeah, it was not very clear. The pathology is not very clear. We cannot comment much on the pathology, but maybe some people also might comment on this. I cannot comment on the mediastinum, the lymph node, because of the rotation. But in terms of investigation, we did expert from this induced sputum, which was positive, low, but also the culture result also was positive. The LJ was negative, but also the reef endocyanized was sensitive on rifampicin and cyanized in the Henny assay. Yeah, so that's the case. I put only the summary. If there is a question, comment on the discussion part.
Yeah, no, thanks very much. I mean, again, a interesting case and well presented. And, you know, the challenge here, I guess, again, is the presentation of TB with malnutrition. But in this case, the child perhaps had other comorbidities, or maybe cerebral palsy, perhaps poor feeding, or poor nutritional intake. But to think of TB was certainly appropriate in this particular child, and the chest X-ray wasn't particularly helpful, but getting the sputum certainly was. So I think well done. Are there any questions or other comments?
Yes, I see the question on the severe acute malnutrition with the MOAC of 12.3 centimeter, but the weight for height was -3. It's already for severe acute malnutrition.
Yeah. I'm sorry, was there a question?
Yes, it was on the chart. Yes, the scoring system that we use.
Yeah, sorry, go on, sorry.
Yeah, I've seen the question on the scoring system that we use. We use the Keith Edwards score, but not the original one. It was being modified with the addition of the chest X-ray. I think the chest X-ray, which is added, is additional parameters. Yeah. So it's the case Edwards score, which you look for different parameters, duration of the illness, the TB exposure, known contact, the X-ray findings, but also the lymph node, but also other extrapulmonary TB features. So you score those parameters, and then you get the score. If it's above 7, that's more suspicious of TB. Yeah.
Thank you. In the original Keith Edwards score that was designed in Papua New Guinea, that there was tuberculin skin test was also included, but I presume you've probably dropped that out.
Mm-hmm.
Yeah. Okay, so any other questions on this particular case? I think fairly straightforward. Certainly it makes it straightforward when you get bacteriological confirmation. So well done. How is the the use of induced sputum in your facility, is that something that's routine? Do you?
Yes, we at our facility we do is a well-established procedures. We do induce sputum in almost all children who, unless if they have other contraindication, but it's something which we do. But also, as I said, this our research is the research facility. So yeah, but if you go to the routine facilities, it's different. It's not something which is done routinely.
Did you have any concerns about induced sputum during COVID, or was that a particular issue? Infection control problems?
Yeah. So generally during COVID, we stopped most of the procedure, but also the way we do, we don't have like the ideal situation like described in the literature's manual, the UV light, those one we don't use. It's just open rooms, it's good ventilation. So that's how we use it. So we put other measures, like putting masks, gowns, all of those measures. So it's not very strict in terms of also using the UV light during after the procedure. But during COVID, like I said, it was under the study setting. Most of the study also were positive also, but also routinely we are not doing the procedure. But later on, we are able to resume just to increase protective measures, the use of mask, hygiene, improving to make sure that all those measures are being adhered to. So, but also, yeah. So that I'll comment. But we were able to initiate sooner when we started also to put in the studies. Yeah, we stopped like 3-4 months, but then we were able to proceed with the routine protective measures. Yes.
So an important question that's been asked is what treatment did you give, and for what duration would you consider to treat for? Would you consider this child to have non-severe or severe TB? In Tanzania, are you considering a shorter regimen, for example, for non-severe TB of 4 months versus 6, etc.? So be interested to hear and whether there was a good treatment response.
Yeah, so we have people from the National TB program, but generally we have not adopted the new WHO recommendation that has been released in. But if you look at the criteria, this one you already, you cannot say smear negative because we don't have, but it's culture, it's expert positive. So it's difficult to comment based on the expert in the setting where you do only expert. I don't know how to interpret those one. It means expert result is a low or very low, but based on the new guidelines, not yet adopted here in Tanzania. But I would like also to hear Alan, if you can comment also on from the national program, if there's any plan. But in terms of response, the response is good. Yes, well, it was good. We didn't have incident where we have few children who died, but generally the response is good on treatment.
Yes, Alan, please.
Yes, Steve. Thank you, Isa, for the presentation. Indeed, we are still using the 6-month regimen for both adults and children. We are yet to start the shorter regimen. However, the plan are now to adopt the new WHO guidelines to include this shorter regimen. So we are in a conversation with the WHO country office to adopt the new guidelines. I think the roadmap will be set to ensure that by the end of this year, we start this process of reviewing our guidelines. Thank you.
No, thank you, Alan. I think that's a really important point. And you see, the challenge, of course, is that, well, SHINE included children who were expert positive, but smear negative. And so those with the lower bacillary load, they did not include smear positive patients. The challenge, of course, is that programs will be just testing with experts, so they won't know whether they're also, if they're expert positive, whether they're also smear positive. In young children, it's obviously less likely. In older children, adolescents, it might be more considered an issue that you would like to use a longer regimen with 4 drugs in the intensive phase when you have multibacillary smear positive disease. But so that's a bit of a challenge for implementation, I think. Sabine, you want to comment to that?
Thanks, Steve. I just put something in the chat. You know what? In the new operational handbook, we try to sort of translate the trial criteria to what is currently being used. So the trial used smear negative, AFB negative, as a criterion for inclusion. If you look at the semi-quantitative results for expert, that will translate in either negative, but also trace results for ultra, and very low or low results. So from that point of view, you would say, well, this could still be non-severe TB. But what I'm wondering is in terms of the nutritional status, because of course you would also be looking at how the clinical presentation is. Is the child severely ill? If there's severe acute malnutrition, you may want to treat for longer. So in that way, there are various factors that one needs to take into account. And there were some interesting discussions also at the regional consultation in Lusaka that was recently held. So yeah, it's really interesting to see what the best way of implementing the shorter regimen is.
Thanks, Sabine. I think that's a great summary of the issues. It's a work in progress, I think, and important that we have these shorter options, but there are challenges for implementation. I think many of the cases are fairly straightforward, but a case such as this is a little bit more challenging, and I think we take your point about the malnutrition as well. Can we move to the next case? Because I know I don't want to I know you have a number of cases from Tanzania, so if we could go to the next.
Maybe, I don't know if I should go through all of them or maybe just few.
Well, I think go through the slides and highlight the main findings. I think the slides are fairly clear, so just highlight the main things as you go through.
Yeah. So this one also similar setup. Participant who came for evaluation or was for consideration to participate in studies. 18 months, male with a body weight of 7. Came with a complaint of cough for 4 weeks and a fever for 3 weeks. And the mother reported a child of cough, which was dry, productive, difficult in breathing, and weight loss. Also, had fever marked during the night for 3 weeks, associated with night sweat and reduced activeness. This one had a non-TB contact, the grandparent, but also the aunt who was on TB treatment. So that one was clear in terms of TB exposure. Next. Yeah. That's medical history. Also was admitted once due to cough, but also malnutrition. Mother was the HIV positive and was on the ART. On general examination, the child was alert, not pale, not jaundice, but also had no lymph node. Was a febrile, rate of 29, plus rate of 100 with a oxygen saturation of 97, the body weight of 7, height of 72, the mark of 10 centimeter. And this one was the weight for HZ score, which was -3 for severe acute malnutrition. On examination, respiratory examination, body breathing, subcortical ingrowing, bilateral capitation, and the wheezes. The TB score was 12. The provision of diagnosis of TB and severe acute malnutrition. So on the lab investigation, I had the lymphocytosis, the HB of 10.8, the HIV was negative, and the TST was 12, which was positive. Yeah, the chest X-ray was to be a separate slides. Also, maybe to comment on the X-ray on the quality also, I think it was not very bad, but it was cut So you cannot comment nicely on the upper part, especially on the rotation, but I think generally the rotation was not very bad, but also in terms of quality.
Okay, thank you. Any questions on this particular case? Again, we have, I think, a fairly similar case, but this chest section, but I think it's fairly clearly abnormal. I think, again, it's a question in this particular case whether you would. I know the child had some indrawing, but not fast breathing. Did the child also have severe signs of severe pneumonia? Was not hypoxic. Would you consider this child as severe TB for a longer regimen, or would you just treat with a short non-severe? That's, I guess, a similar question to last time.
Yes, hello. Sorry, I think I was interrupted. Interruption, but
I guess I was just trying to discuss again whether you would consider this child to have, a severe TB requiring 6 months of treatment, or non-severe. Certainly, the child clearly has bacteriologically confirmed TB with an abnormal chest X-ray as pulmonary TB. So, yeah.
Yes. For this one, I would consider, not adopted, but with the new guardian, I would consider for the 6 months regimen based on the X-ray finding. Yeah.
That's right. I mean, the X-ray findings in the SHINE trial was that if there was involvement of more than one lobe abnormal, then that's considered radiological evidence of severe disease. So any other particular questions in relation to this? So Rita's asking, do you actually use LPA for children in Tanzania routinely?
No, we do not do routinely, but only because it's also in a such setting you have the luxury of doing all those, but routinely is only available in the reference lab in Dar es Salaam, but we have at our local lab here, which is a dedicated research lab. Yeah.
Okay, and this child you're going to treat for 6 months. How did the child do in response to treatment?
Yeah, progressed very well. I may not have for all the kids, but generally most of the kids we didn't have incident, but generally all the kids that we put on treatment, we had a very good treatment generally. But these are the kids that we saw like 2 or 3 years back, not recently.
Sure.
So
okay.
Yeah.
Thank you.
Yeah.
Great. All right. Next patient.
Yes. Again.
Thank you.
In similar setup with the previous two, a 1-year-old female with a weight of 7.4, chief complaint of 8 weeks, but also fever for 1 week. Mother reported the child to have cough on and off, associated with the loss of appetite, with weight loss and reduced activeness. Low-grade fever during the night, also associated with night sweat. Also here, there is a known history of TB contact with a grandparent who was on TB treatment. Next. Yeah, no history of previous admission. Reported the history of being put on several medication due to the precedent complaint, which provided minimal relief. But on examination, it was alert, not pale, jaundice, no jaundice, no lymph node, but also was a febrile, respiratory rate of 22 and a pulse rate of 110, oxygen saturation of 29, weight 7.4, height 7 centimeter, and the MUAC 132, and the standard deviation was -1, which for mild malnutrition. Respiratory examination was normal, bilateral palpitation, the TB score was 12 also. On lab the provisional diagnosis of TB with the mild malnutrition. Lab investigation had leukocytosis, lymphocytosis, but also neutrophilia HB of 7.4, so severe anemic. HIV negative, but also had the positive TST. Next. Yes. Also this one for the X-ray, the rotation is not very good, so difficult to comment on other pathology, but generally, but in terms of exposure, I don't know, I think it's a relatively good exposure. Yes. Yeah, but he has a heterogeneous opacities in both lungs. I don't know the issue, but also the trachea, you cannot comment clearly because the poor rotation, but also in terms of the lymph node, I think it's clearly visible. There is no obstruction of the airways. Yeah, and then on the investigation, gene expert was positive again. The midget culture was negative, and also the LJ was positive, the solid culture, and also the hen was sensitive for RIF and the isoniazid resistance. There was no RIF or isoniazid resistance. Yeah, thank you.
Thank you. Again, I think fairly straightforward case. And as I say, it's certainly straightforward when you get a bacteriological confirmation. What proportion of your TB caseload in the hospital there in Dar es Salaam is bacteriologically confirmed, do you think?
Yeah, we selected the cases that were positive, but we have cases that were negative as well. I think we should have mixed maybe, but generally, if you look for those that we have, the cohort that we took, the proportion of bacteriological confirmed also is very high. I think of 20 to 25% is very high. But if you go to routine setting, it's very, very minimal. We have another clinic here. We are working with Bella. If you look at the proportion of microbiologically confirmed is very, very low, maybe
Okay.
5 to 20%. But also if you go to more routine facility, you may find basically almost no microbiologically confirmed cases. So here it was more biased because of also the facility. But if you go to routine, the microbiological confirmation is very, very low. There may be almost zero to most of the facilities.
Okay, thank you. And Maureen has asked, in some of these children, there was history of contact. And do you think that these represent missed opportunities for preventive treatment? Was there an opportunity when you think back on these cases where the grandparent, for example, had TB, etc., where the child might have been identified as a household contact and treated for preventive treatment before developing TB?
Yeah, it could be, but generally also this, sometimes you find that at the time when there could be a missed opportunity, but also it could be by the time you diagnose the index case, maybe also in a short time, few months later, also you find that you have kids who have TB symptom, or sometimes also they have symptoms together. So generally, for kids that come for screening, also we screen them. If we rule out TB, we usually refer them. They get the TPT, but it's challenging for those who come for the first time. But yes, it could be the missed opportunity during the index case was being evaluated for the first time. Yeah.
Yeah, thanks, Dr. Issa. And what steps do you take to rule out TB, as you say, if you have a child contact? Do you routinely chest X-ray asymptomatic children, or do you just rely on symptom screen, for example?
Routinely, if you go to most of the facility, they use the symptomatic screening. It's not necessarily that you do the chest X-ray. In most cases, also, it's not something which readily you can access to. Yeah, so most of the time it's just symptom screening, if the child is okay, no symptom, then they initiate on TPT.
Right. Okay, well, I might ask you to keep going at this point. Others can write questions in the chat. I think this is your last case, is it? Case 4?
Yes, the last one here, case 4
Yep.
is. Yeah, this one was the older child, 14 years old, female with a weight of 29 kilo. Presented with cough for 3 months and fever for 8 weeks. She reported history of cough for 3 months, productive, yellowish, non-blood stained, associated with chest pain, and the vomiting for 3 days. Low-grade fever for 3 weeks, associated with night sweat, which was relieved by paracetamol, but also had no known history of TB contact. Next. Yes, no history of previous admission, as medical history. Also reported history of being put on several medication due to present complaint, and was on paracetamol at the time of the admission. On examination, general examination, he was alert, not pale, not jaundiced, so no lymph node enlargement. Was a February with the pulse rate of 20, pulse rate of 120, but also oxygen saturation of 97, weight of 29, 8, and the BMI of 14.6 kg. I don't have the data, the BMI for age for this one, so I cannot comment much on in terms of the severity. But on respiratory, reduced air entry on left is pulmonary area, patient on the left lung, and the TB score is 9. Provision diagnosis was the pulmonary TB. The investigation had leukocytosis, microphilia, HB of 11, and there was HIV negative. The TST was positive with 18 millimeter. Next. Yeah, also here, the chest X-ray, maybe it was overexposed, but you can see sign of cavity, especially on the right side of the diagram, on the right upper lobe, maybe also in the middle, beside you can see some 2 cavities there, maybe also on the right side, especially on the upper left lobe. I think there's some involvement pathology there. So I think this one was a typical for pulmonary TB, I would say. And also the result was expert positive, which is not surprising. Also culture, midgets, and the LOJ were both positive, but also the hen also was positive, and the leaf and the sonazid was sensitive to leaf and the sonazid. Thank you.
Yeah, thanks, Dr. Issa. So interesting child again with more adult type disease, expert positive. Was the expert tested for rifampicin resistance as well, or was it just the Hain?
Yes, because this one it gives automatically. Once you give, it gives. So if it come direct. So here it was not indicated, but it was not detected. Yeah.
And again, this child, though had no contact, this child's quite malnourished as well. I think malnutrition has been a bit of a feature of the cases that you've presented today. I think the child was just adolescent was just 29 kilos with a very low BMI. So again, the presentation of malnutrition is evident, but despite that, a positive skin test. But yeah, clearly, I think this child shows adult type disease where you often get a high yield of bacteriological confirmation. So how long are you going to treat this? How long was this child treated for? This adolescent, sorry.
Yeah, again, I don't know.
6 months.
Yeah, 6 months. But I don't know if you follow the shorter regimen for the other shorter regimen with the rifampicin. I don't know if we qualify for the shorter.
So are you using that in Tanzania? That's a 4-month regimen.
No,
you're not
yet. No. Yeah.
That's a regimen using isoniazid, rifampicin, pyrazinamide and moxifloxacin. Yes, is that what you're referring to?
Yes, yeah.
But that's not being used yet in Tanzania. Okay.
No, not yet, yeah.
Yeah, no, so this child needs, for standard regimen, at least certainly 6 months, using 4 drugs in the intensive phase. And I presume that's ethambutol still in Tanzania?
Pardon?
The 4th drug is still ethambutol?
Yes, the ethambutol.
Yeah.
Yeah.
Are there any particular, oh, hang on, there's something in the chat. Any contact screening done for this adolescent? Yeah, this child
Yes,
is, yeah. Sorry.
yes, according to our protocol for all, even for children, if we have a positive child, also usually try to visit the family or ask the family if there's other kids who present with TB symptom, who also welcome them for evaluation.
Right.
Mm.
And can I ask about whether the child was admitted as an inpatient or managed as an outpatient, and what infection control issues you might have had to address?
Yeah, the other one was outpatient, and most of the kids also we see in outpatient, but we have also usually a few inpatient cases that we detect in the ward. But generally, in terms of infection control, we do not have like a separate ward. We do not have a separate ward for TB, for example. So we find most of these patients you find in the general pediatric ward. So you just need to detect them early, to suspect them early, and if you diagnose them, also put them on treatment early. So that's how we do. But even if we diagnose them, we not necessarily that we separate them. Yeah, even if they're admitted.
Thanks, Dr. Issa. And Maureen's asking about this adolescent. Was he at school? Was that an issue? Education, continuing education, was it interrupted, etc.?
I do not remember. I do not remember if there's issue with school, but generally, if they are sick, you find it commonly. Like I said, these kids that we saw, like this one we saw, I don't know, like 2020. So I may not have most of the details for now about the schooling issues. But we have kids who have, during the sickness, they don't go to school, but when they recover, they become better, they continue normally with their schooling. But during the acute, they might have some interruption with school going.
Can I ask generally, how long would they be out of school for? Would it be 2 weeks or 4 weeks, or what would be the normal practice?
Pardon?
Once they're on treatment? How long do you think, how long would the school be interrupted for normally once they're on treatment? When is it okay for them to go back to school?
Yeah, so there's no clear guidance on how, but generally for most of these kids, in terms of transmission, if you treat at least 2 weeks, you presume the transmission is not very high, but generally also look on the strengths, how stable they are to proceed with the schooling. But generally, there's no clear guideline for these cases for how long you should keep them at home. It most based on the parents, but also on maybe on the clinician who's treating the patient, or to advise the parents.
Yeah, thank you. And if this child was at school and then came in with this chest X-ray high bacillary load, do you actually do any further investigation as an outbreak in the school or not? Generally not?
No.
No.
No, but that family, yes, yeah.
Just family, okay.
Yeah, but I know, maybe also can comment on this, the national TB program, how they usually do it. I know there's a lot of community, whatever, TB intervention, which they do, but.
So Alan, are you able to comment about that, about whether you would initiate an outbreak response at school?
Sorry, Steve, I couldn't get you properly. Can you come back?
Okay, so we've got an adolescent with smear positive disease, adult type disease, who's been at school recently. Maybe not this child, but just theoretically. We want to screen the other household contacts, but do you actually screen, or do you do anything with the school in terms of investigating the outbreak for further case detection or preventive treatment?
According to our national guidelines, that is not the way we are doing. What we are doing now is to conduct it to the household contact of these index cases. However, we have a school health program whereby to those boarding schools and those who are on a congregate setting, we usually conduct some sort of screening on not only routine, but sometimes during the campaigns, whatever. But we don't have this attendance or a practice of screening to the rest of the schoolmates.
Right. Okay. Well, thank you. Maureen, can you speak to, Maureen, would you like to just share your experience in this sort of type of challenging situation in Uganda?
Yes, thank you, Steve, and greetings to you all. Maybe similar to the experience in Tanzania. It is not, so we document TB among a school-going age group, but the focus has mainly been on household contact investigation. The program has now expanded to include a close contact. However, the scenario that comes to hand is what we documented in 2017, where we had more than one adolescent in the same school that had TB. And at that time, we were prompted to go into the school. These two adolescents had defaulted on treatment, and we were able to diagnose 30 active TB patients. Within that contact investigation process, and they were linked to care. So the challenges that were really highlighted were, of course, the stigma, adherence, and treatment support issues. And also, this was a boarding school where the parents had not disclosed for the initial two cases. The parents had not disclosed to the school, so it was challenging for the adolescents to continue treatment while at school. So under a program setting, it's challenging to do contact investigation in the context of school health. But what we are doing as Uganda, we are working with the districts. At each district, we have a district education officer, and these have been engaged really mainly to via orientation on the basics about TB. And we encourage the health workers, if they identify an adolescent school going beyond household contact tracing, they should also follow up with the schools where the learners are attending. Over.
Thanks, Maureen. Thank you. I'm sorry, I've just been reminded we have some more cases. Moses, I think. So thanks, Dr. Issa. That was excellent. 4 really clear cases and illustrated a lot of issues. Thank you. Well, I think if we can move to the cases by Moses, please.
Good afternoon from Uganda.
Thanks, Moses.
Moses, working with Baylor, Uganda, as a Center of Excellence. So I have one case to present for today. May I see the next slide? So briefly, is someone we attended to at the first visit or contact. They were 14 months old and of unknown HIV status, who had been admitted at the nutrition unit following a 5 months history of wet cough with no de novo variation or aggravating or relieving factors. and they had had fever and poor feeding, as well as poor weight gain for 3 months prior to their admission. And 2 weeks prior to their admission, they had difficult breathing. And it was also noted that despite not reporting confirmed TB contact at home, there were chronic coughers and smokers within the same household. So this same child had chronic diarrhea and reportedly had received all the vaccines that are recommended, but had not received the measles vaccine at 9 months. So while on ward, she had been managed with antibiotics, that was ampicillin and amikacin, which were later modified to include ceftriaxone, I think, following delayed or no much improvement on the baseline antibiotics that they began with. Next. So on our interaction with the client at the facility, the clinician noticed that the child was looking sick and wasted, but had no edema. The weight then was 7 kilograms for a 14 months old. The height was 72.8 centimeters and a mark of 11.5 centimeters. This could have changed because the child was already on the nutrition unit receiving some management. So the weight for height, Z-score, was negative 2.74, and weight for age was negative 2.64. At that time, her temperature was 38.4 with a heart rate of 156 beats per minute. The saturation was 93%. And we had palpable lymph nodes in the cervical and axillary areas. It wasn't stated whether these were matted or not, but they were reportedly tender. And significant also on the respiratory exam, we had fast breathing of 64 breaths per minute, and crepitations at the right inframammary area. Next. So then, that was our problem list. We had a child who had severe acute malnutrition with no edema, chronic cough and chronic diarrhea. And we presumed that this child could have been infected with HIV and with advanced stage of HIV, simply because the mother had also newly tested positive while she was nursing the child on ward. So routinely we have people who hope to identify these, we would say, high risk for HIV infection and try to test them, to offer them tests while on the ward. And this is how the mother was discovered and the exposure to this child. So on that day, routinely we ask for baseline labs, including the CBCs, RFTs, LFTs, the Hep B and TPHA. So then the CD4s for those that have tested positive for HIV. So for our CBC, we had a slightly high white cell count and an HB of 9.3, which was also mildly low. The electrolytes, only the sodium was relatively low, but the others were within range. The LFTs, we had the AST at about 51 international units, which was also slightly elevated. So next. On the same day, a PCR was requested, but much as we do point of care, this we were not able to get on the same day. So we received that result on the following day, as well as the chest X-ray, which image I don't have, but from the clinician's notes, there was obliteration of both cardiophrenic angles with heterogeneous opacities in the lung fields bilaterally. So then, following discussion with fellow clinicians, a diagnosis was made clinically for TB. And we also had a positive outcome for their DNA PCR. So at this time, the diagnosis was HIV disease advanced with pulmonary tuberculosis that was clinical, and then severe acute malnutrition with chronic diarrhea. Then a week into treatment of TB clinically, a gene expert result on the stool and then nasopharyngeal aspirate was received, and it was positive for MTB, but no resistance to rifampicin. So also to note, this is someone that got enrolled in our care and investigation for TB through one of the studies that is done at the facility. So we were able to have stool and nasopharyngeal aspirate gene experts done, plus the X-rays at the cost of that study, because these are not routinely done for children that we often see. Next. So we started.
Moses, if you can just sort of get through the main points, because we're going to run out of time. I'm sorry.
Yes.
Yeah.
So we started management for TB initially clinically, and we continued with that even after the confirmed diagnosis, and the patient was being followed up still on the nutrition unit where they were admitted. So we reviewed them 2 weeks into TB treatment, and they had some improvement with some weight gain and change in work, as well as less distress. The respiratory rate was lower than the initial one. So we again started them on ART treatment as per our national guidelines. First line is ABC3 TCD-TG, which we did, and we doubled their dose of DTG to cater for drug-drug interactions with the anti-TB meds. So next. So we again followed up the patient that was last month, when they were about 2 months on the anti-TB treatment. And that day they were really with great improvement, with a noted weight gain, height, and the mark, which had improved greatly. And they were playful and happy. So we expect to see them next month as per the study protocol.
Yeah, thanks, Moses. Excellent, very clear presentation. And I presume that the study that was going on was TB Speed, was it? The one that did stool and nasopharyngeal aspirate?
Yes, it's okay. It's basically a study that is also dealing with novel diagnostics that are not routinely done.
Yeah.
So it's what helped us to do those investigations.
Yeah, no, that's great. It's interesting that you had a yield from those samples because traditionally they haven't been used as frequently. The stool and the nasopharyngeal aspirate, the yield is not quite as high as gastric aspirate or perhaps induced sputum, but certainly you can get bacteriological confirmation using those samples. So that was interesting to see. So thank you. Any particular questions from anyone in the chat? While you're thinking, I'd like to make the point, I think Rita has also made the point, what we've seen from these cases today is the presentation of TB in the context of children who are malnourished or failing to thrive. And this is an important reminder yet again of the importance of thinking TB in the context of children who are losing weight or not gaining weight. And one of the critical tools that at least we used to use at least a lot in a country like Malawi or in other places is the Road to Health chart, which are often kept quite well, at least up to the first 2 or 3 years of life, where you can get a nice tracking of what the weights have been doing over time. Every time the child gets immunized, etc., weights are done. So I just wonder whether, in future presentations or in that context, are people using those weight to health, those Road to Health charts, those weight charts as a way of being sensitive to thinking of failure to thrive, weight loss, the possibility of TB, and also to treatment response, which is also critical. So any comments in relation to Road to Health cards? Moses, do you use Road to Health charts? The
growth, are they the growth monitoring charts in our setting? Yes, they are they're actually growth monitoring charts, but also coupled with the immunization schedules.
Yeah.
The unfortunate bit is for many cases like this, we don't have the mothers presenting with those documents for the initial visit. And like for this case, the mother just knew that the child never received the dose at 9 months, which was the measles vaccine, but then it wasn't clear whether she had like a confirmation by the count.
Okay, thank you. Any other final comments? I think it's time. We've done very well. We've got through quite a few cases, and I appreciate the fact that you've all prepared to present. Maureen is saying thank you for the great presentations. I second that, and as does Rita. So, look, I think it's challenging by Zoom to manage this, but I would just really probably like to close and say thanks again. Important learning points, I think, are fairly clear, and we look forward to the next round of clinical presentations. Hopefully I'll have some opportunity to present some cases from Melbourne as well, or have others from other parts. So Some of the presentations today were fairly straightforward because we got bacteriological confirmation. I think it'd be also good to have cases that require clinical diagnosis in future discussions. And Mandela is saying that stool is a great test sample to use. So thank you. Rita, I might hand back to you just to close if I could, or John Paul. Thank you.
Thank you very much, Steve. And thank you indeed all presenters for preparing the slides after selecting the cases from your archives, from your records, and making the effort. So thank you, Chris, Issa, and Moses. And obviously, thank you everyone who was able to attend today's grant round. I wish that you have picked up certain learning points that you will be perhaps putting across in your networks. I have definitely had a fantastic refresher of what's happening, let's say, Mozambique, Tanzania, and Uganda. We have recorded this webinar, colleagues, not quite from the beginning, but almost from the beginning. My apologies to you, Chris, for missing perhaps the first one or two slides. And this recording will be posted onto the COE webpage, which is situated on the Union's website. Please do go back and view it, listen, and share it again in your networks. Thank you once more. Keep safe and think TB in children and adolescents. Thank you, everyone, and bye.
Thanks, everyone. Bye.
Thank you. Bye-bye.
Bye.
Bye.
Thank you. Thank you very much.
Bye.
Bye, everyone.